Welcome to this presentation from the GHAPP MASLD Community Network. My name is Maribeth Capuno. I'm an adult nurse practitioner. I work in hepatology in Richmond, Virginia. It's not moving.
You might just want to try clicking with your mouse.
Nope. Oh, there it goes. Okay, tonight our patient is Ashley. Ashley is a 52-year-old woman, and she's been referred for evaluation of an abdominal sonogram showing mild hepatomegaly and increased hepatic echogenicity consistent with the steatosis. She feels well, hasn't had any major complaints. So her past medical history is she's got polycystic ovarian syndrome, high blood pressure, hyperlipidemia. On exam, her liver is smooth, it's not tender. She's on amlodipine and atorvastatin for her hypertension and hyperlipidemia. She's also taken multivitamin and milk thistle, probably because she's heard it's really good for your liver. And she averages 2 glasses of wine a day. In clinic, I always talk to my patients too, just to find out, what size their glass of wine is, because some people have bigger glasses than other people. So we get her vitals and we do some labs, and her blood pressure is still a little bit elevated, not really well controlled. Heart rate 76, she's afebrile, weighs 161 pounds, and she's 5'2", so that gives her a BMI of 29.4, overweight but not yet obese by the BMI standards. ALT and AST are both elevated. ALT phos might be mildly elevated, above 120, and bilirubin looks fine. Platelets are good. A1C shows her to be pre-diabetic, and her triglycerides are slightly elevated above 150. So we do a FibroScan just to do some further workup on her liver to see if she's got any evidence of steatosis or fibrosis. And her KPA comes back at 11.4, which is suggestive of F3, which is starting to get to where we're very concerned that she's leaning toward advanced fibrosis. And her CAP score of 310 suggests that she's got severe steatosis. Oops. Uh-oh. I need to go back to. There we go. Now it's working. Okay. So steatotic liver disease is a spectrum of diseases. There's metabolic dysfunction associated steatotic liver disease. Those are people that have diabetes, high blood pressure, hyperlipidemia, obesity. It can develop into MASH once they've got evidence of advanced fibrosis or ballooning on a biopsy if that's available. We also know that there's alcohol-associated liver disease. There can be steatosis caused by certain medications. Certain illnesses can cause fat to develop in the liver, and there's also unknown causes. The question is, and the tricky area is, when you have somebody with metabolic risk factors as well as alcohol intake, and where do you just determine, where they fall on that spectrum? Are they, mostly metabolic? Are they purely alcohol with some metabolic underlying factors, or are they somewhere in the middle? So we like to do a good assessment of our patients' alcohol intake to determine what their levels is. The recommended weekly alcohol intake for women is anywhere from usually around 140 grams of alcohol, which would be about 1 drink per day. And in men, it's 210 grams, which is about 2 drinks per day. So their daily alcohol level, you want to keep it on the lower end. And usually anybody with steatosis, we usually recommend that they not be drinking. So we like to tell our patients, one of my favorite things I always hear is that, well, I don't drink the hard stuff. I only drink beer. And just trying to make them remember that any alcohol going through the liver is still alcohol. Your liver cannot differentiate whether it was a beer, a glass of wine, or some good old moonshine here in Virginia. But 12-ounce beer or 9 ounces of malt liquor, 5 ounces of wine. If they're drinking heavier wine like port, it's a little bit less. And if they're drinking a liqueur or an aperitif, it's even less, 2 ounces versus the 5. And then again, 1.5 ounces of liquor. So you want to make sure that when you ask them about their drinks, ask them if they're measuring or are they just eyeballing, because the majority of people are just eyeballing their drinks. So the reason we are concerned about alcohol intake on top of the metabolic factors is we know things like insulin resistance, diabetes, obesity, visceral fat can lead to your liver storing fat. And then if you have alcohol intake on top of that, that also can lead to the storage of fat. When you add alcohol to the mix, there's a little more stress in your liver. The ethanol production can lead to other microbiome-derived products. It increases your inflammatory response, and it accelerates the progression of fibrosis. So this little cartoon shows us really well what the risk estimates are for having your liver disease become decompensated based on your fibrosis stage. And then it also shows across the bottom if it's pure MASLD, if it's a mixture of metabolic and alcohol-related steatotic liver disease, or if it's purely alcohol-related liver disease, how quickly you can progress. So even with low-risk fibrosis, so F1, your 5-year risk of decompensation increases significantly with the addition of alcohol. You go from less than 1% to a 5-year risk of up to 15% with purely alcoholic-related liver disease. So you also want to look at, what other factors they have in, what other genetic factors are there that can also increase their risk of fibrosis, because all of those things can lead to your increased risk of decompensation. So how do you know if your patient is actually using alcohol? Of course, we always, first thing you do is you ask. And the reason we're concerned is what I like to tell my patients is when there's any kind of inflammation or injury to the liver, using alcohol is basically like pouring gasoline on a fire. You're increasing the inflammation, you're increasing the risk of developing fibrosis. So you always want to help them, know that they need to increase or they need to maintain control of their metabolic factors, such as diabetes. When you add alcohol to the mix, it's not really helping their diabetic situation. It also can have some inhibitory effect in their control of their dietary intake. And then over time, the continued insult and inflammation of your liver is going to increase your fibrosis, and it can lead to cirrhosis. So again, the best ways to assess your alcohol intake is a questionnaire, the AUDIT. You can have the patient self-administer their audit, or you can ask them the questions yourself in clinic. It's really interesting because our FibroScan person will ask our patients their audit questions, and then we'll also ask them in clinic, and we often get very different answers. You can, there are some indirect methods to measure for alcohol intake. Your MCV, your GGT can let you know if a patient has a history of alcohol intake without a direct alcohol test. Other common alcohol tests are like urine ethanol. You can test, excuse me, you can test hair for alcohol, but, excuse me. If you use hair products that are alcohol containing, that can affect the alcohol content in a hair sample. The CDT is carbohydrate deficient transferrin. That is a good test to determine alcohol. And the ANI is a questionnaire, or it's an index, and it helps you determine whether it's more metabolic fatty liver or more alcohol related fatty liver. Another test that can be used is a PEth test that measures alcohol over the last 3 weeks. But you should screen. In our clinic, we like to screen everyone at their initial visit. And the way we present it to the patients is we're just checking to see how the alcohol is affecting your liver. You definitely want to look at the results because they can tell you whether the patient is having moderate to excessive alcohol. And a lot of patients that are considered non-alcoholic fatty liver, 28% have alcohol use, and 25% of those with just metabolic related. So optimal diagnosis, you want them to be very sensitive and very specific, and that's why they're showing here the area under the curve for the hair ethanol and the if you combine the hair alcohol, the urine alcohol, and the AUDIT, you seem to get a better overall test. Okay, so gaps we have in the assessment is we know that if your patient has metabolic dysfunction, you might want to, you have your regular evidence, your BMI is elevated, their fasting glucose can be greater than 100, blood pressure greater than 130/85, or they're on antihypertensives, triglycerides greater than 150. You might have an HDL that's less than 40 or less than 50 in a female. But then sometimes you might just see the hypertension or the hypertriglyceridemia in isolation. And if it's just a one-time thing, it may mean nothing, but you definitely want to watch for that. If they don't have evidence of alcohol use or you question it, that's when you might want to think about PEth testing to look and see if they're just not being honest with you, or maybe not even being honest with themselves about their amount of alcohol. So you want to quantify the alcohol in grams per week, and you estimate it by whatever a local standard drink is. You ask them how often they're drinking, do they binge drink? I like to ask my patients to define to me what it is, because they'll say, oh, I don't drink that often. And I'm like, well, okay, well, how often is often to you? Or they'll say, I drink occasionally. And I'm like, well, what's occasionally? And it might be 3 or 4 days a week is what they consider occasional, or someone else may only consider it every 6 months that they have a drink. And then I also ask them if they use a jigger to measure their alcohol, or do they just eyeball it? What size glass do they typically use? And I just tell them, I'm just trying to get information so that I can make sure that we're doing the best for you. You definitely want to know if they've had any history of alcohol-related injuries, or if they've been hospitalized. Have they had alcoholic hepatitis? Have they had any DUIs or episodes where they or someone else was in an uncomfortable situation? Alcohol use in women, you can, if they're between 140 to 350 grams per week in a female, or 210 to 420 in a male, and they have a PEth score of 25 to 200, you can consider them having mixed MetALD. If their alcohol is greater than 350 grams a week in a woman, or greater than 420 in a male, and their PEth level is greater than 200, you can call them alcohol-associated liver disease. You definitely still want to do your diagnostic where you rule out your autoimmune, your drug injuries, anything else that could be leading to your findings. This is just highlighting, looking for the hypertension and the hypertriglyceridemia, and also the alcohol biomarkers. Again, sorry, I talked through all this, but if you see an episode where they just have like an oddly elevated blood pressure or an incident of elevated triglycerides, the PEth testing may help you see if alcohol might be leading to those findings. So in our patient, we did a PEth level on her, and her level came back at 120. So she comes back in that range of moderate to heavy alcohol consumption. If you notice, though, PEth is very good at diagnosing whether they have very little alcohol, moderate to heavy levels, and greater than 200, again, would be considered excessive alcohol. All right, so the PEth test. The nice thing about it is it's detectable for 3 to 12 days after one single binge drinking episode. So if somebody was just like went out on a weekend and decided to go on a total bender, but they don't drink regularly, the PEth level is still going to pick that up, whereas your blood alcohol level will pick it up, but then it declines rather quickly. It also doesn't really vary by your sex or gender or your BMI. It's a very accurate test, and it can let you know for an extended period of time. Okay, so then there was a study done about alcohol use in individuals with excess weight, and they screened 659 and ended up with, I think, I'm trying to remember, 236 after they went through how many didn't drink, how many were enrolled or didn't meet the alcohol consumption criteria. And of their patients, they found 11 females who consumed between 140 and 350 grams a week, 9 males between 210 and 420. And then they had 21 females where the PEth was greater than 25, and 56 males where the PEth was greater than 25 also. So they were analyzed and they were suspected to have MetALD, which was the combination of metabolic and alcohol related, and 15% are at risk just by even minimal alcohol use. So again, it's got the exclusion criteria in here that some were excluded because of other illnesses that could be causing their ongoing steatosis. So going back to our patient's medical history, the polycystic ovarian disease, hypertension, and hyperlipidemia. So hypertension and hyperlipidemia, especially elevated triglycerides, do have an association with alcohol use. So there's been multiple studies on alcohol use in hypertension, and a review of 32 random controlled trials with 767 participants showed that alcohol had a biphasic effect on blood pressure, and that for the first 12 hours after consumption, it could decrease their blood pressure. But after 13 hours, it does increase blood pressure. So multiple trials showed the mean difference in high dose alcohol compared to placebo, how this over time, the systolic blood pressure would elevate, and the amount of elevation and the diastolic changes as well. There was also some change in the heart rate, and it's interesting too. I mean, I don't know if anyone's ever taken care of patients when they're in the hospital and they're not getting their alcohol. You often see them have some issues when they're getting their medications. So also alcohol and hypertriglyceridemia has been studied, and this study showed how triglyceride concentration over 10 hours after drinking 2 standard drinks or just water, and what the changes were. So they compared patients who did have high triglycerides and also patients who did not have a history of high triglycerides. And in both groups, giving them water didn't show a spike in their triglycerides. However, giving them alcohol, even in patients with no history of high triglycerides, did show a spike in their triglycerides over time. So back to Ashley. So she's 52. We know her history. Her ultrasound showed hepatomegaly and increased echogenicity, which was consistent with steatosis. She felt like she was doing well. FibroScan was suggestive of F3 fibrosis and severe steatosis. Labs showed the PEth count of 120, showing she's drinking more than she probably should. Physical exam was really unremarkable as far as any feeling of hepatomegaly or feeling of a nodular liver. So we know based on her FibroScan and her testing results, she does have MASLD, and it's predominant MetALD. So she has a combination of her metabolic factors and her alcohol use. So current treatments, what is available for her? We definitely want to go with the good old standards. We want to give her Mediterranean diet, increase her physical activity, encourage 5 to 10% weight loss because we know that that's helpful. She might be a candidate for resmetirom or Rezdiffra. Definitely want to talk to her about her alcohol use and really recommend cessation of her alcohol because, again, as I said earlier, she's basically pouring gasoline on a fire. She's already showing evidence of advanced fibrosis and significant steatosis, and the alcohol can just increase the progression of that. And because she's showing evidence of advanced fibrosis at F3, we would recommend hepatocellular cancer screening with every 6-month ultrasounds and AFP just to give you an additional marker to verify. So what would be the ideal definition for clinical trials? I want to have some objective biomarkers that can overcome underreporting of alcohol use and standardize the assessment of recent alcohol use. And also it can be used to certify their abstinence. You want to have your patients buy into this. You don't want to make them think you're tricking them or that you're reprimanding them. You want to look at any drivers of liver disease that are present. You want to consider more than one cardiometabolic risk factor or ensure that they've got hypertension and hyperlipidemia after they stop using alcohol. And that would let you know that it is definitely metabolic related as well. And then you want to look for exposure to additional risk factors. So they have to have had those risk factors for at least the last 6 to 12 months. Again, when they mentioned like the isolated episode of hypertension or high levels of triglycerides. So take home, there's a new definition. It's MetALD, which is a combination of metabolic and alcohol-related liver disease. And this is when your alcohol intake is beyond the recommended 140 to 350 grams in females and 210 to 420 grams per week in males, respectively. Clinical criteria can underestimate MetALD or also alcohol-related liver disease. So you definitely want to look into some alcohol biomarkers. You want to look for the drivers of liver disease that are present and continue to reassess their metabolic dysfunction. You want to monitor their A1C, monitor their insulin resistance, monitor their lipid levels. And you want to make sure that they've been exposed to those risk factors enough to call it metabolic related liver disease, as well as the alcohol related. For clinical research, you want to facilitate an objective MetALD diagnosis, allowing for comparisons among the different sociocultural realities. So everybody's got different, we know that there are different interpretations based on cultural use of alcohol, and we want to make sure that we are not excluding people based on their cultural norms. So if you have any other questions, please reach out to the GHAPP MASLD Community Network. We have additional education available at any time and are happy to answer any questions that you pose. Thank you for your time.